Hi, everybody. Can you see my slides?
Yes, I can see your
Okay,
slides.
thank you. I'm Dr. Scott Irwin. I'm a psychiatrist, and I run the Patient and Family Support Program at Cedars-Sinai Cancer. I've been there a little over 10 years. I previously was at UC San Diego in a similar role, and I actually started my career in hospice and palliative care back in San Diego as well. So today I've been asked to talk to you about managing stress and anxiety. It's going to be fairly high level, but there will be time for questions at the end. And certainly if you put some in the chat and our person is able to monitor it, let me know. I can try to answer as we go. I'll also pause from time to time for questions. So the first thing I want to talk about is what is stress, or in cancer, we call it distress. It's emotional strain or pressure, troubling, confusing, maybe out of the ordinary. And it's an unpleasant experience. Sometimes it has psychological implications, sometimes social. It might be spiritual, or it could be physical distress, like pain. So what's the difference between that and anxiety? Well, anxiety, like stress, is a normal transient response to stress, and it may help with the warning of danger or actually coping with stress. So actually, anxiety, when it's normal, is a good thing. But when does it become concerning? When you have excessive feelings of uneasiness or worry, when it's generalized and unfocused, so this generalized sense of worry, and there's not a specific thing that's causing you worry. And you may have physical symptoms with it: muscle tension, restlessness, fatigue, shortness of breath, feeling butterflies in your stomach, not able to concentrate, fear or dread of a future threat, low energy. I had a patient yesterday. She felt like an elephant was sitting on her chest, and not in the worry about her heart way. When I get anxious, this is how I feel way. Um, and the way that anxiety disorders differ from normal fear or anxiety is that they're excessive and or persistent. So they're not this transient normal coping. They're there with or without triggers, and they don't go away. So do you have anxiety? Some of the things that to ask people or screening questions to get a sense is: do you worry a lot? Are you often fearful? Do you feel anxious, nervous, or on edge? The last one is my favorite. It's like, would your family, friends describe you as a worrier? That's often my tip off that somebody has anxiety beyond what would be considered normal. So what can trigger distress or anxiety during a cancer experience? Well, new symptoms or worsening or uncontrolled symptoms, learning about the diagnosis, testing or scans or waiting for the results during treatment and post-treatment surveillance. I find that, and many of you that have been through the experience probably have experienced that, patients will get very anxious right before getting the scans, and then that period right after while they're waiting for the results. And then during surveillance period after treatment, often worried about that other shoe dropping and when is it going to drop. It almost never goes away. Waiting for that start of treatment or treatment-related side effects, or from diagnosis to first meeting with the oncologist and learning the plan. I find that period of uncertainty and not knowing what's going to happen and what's coming is really high in anxiety. In fact, the same patient I saw yesterday had felt really good the last 2 days because now she had seen her oncologist and had a plan. Her anxiety had gotten out of control when she got the diagnosis, but before she had any information. Also, transitions in care can be really hard. Discharge from the hospital, end of treatment, especially when people are moving away from seeing a lot of providers a lot of time to not having many appointments and not seeing a lot of people, learning that their cancer progressed, transitions away from cancer treatment, and also long-term survivorship. If you're not on mute, if you could put yourself on mute, that would be great. We're getting a little bit of feedback. So what else can increase distress? Well, people that have spiritual or existential distress. Why is this happening? Why me? Social factors, so ability to communicate, level of family conflict or support, level or lack of social support, living on your own, having unstable housing, unstable food, immigration status, children, financial stress as well. Also, this is a big one. I find that helping people sleep makes everything better, but especially stress. Mental health issues can also lead to stress. So having a poor state of mental health before the diagnosis, or a pre-existing mental health diagnosis, or having substance use issues, all increase the stress. Often a younger age in cancer patients increases the stress. Traumatic life experiences, the loss of a loved one, having experienced assault or abuse or life-threatening accident. So traumas in a way are additive, and getting a diagnosis of cancer is like getting a trauma. So the more traumas you've had in your life, this is just one more that is adding to it. So this is sort of the distress continuum. There's sort of what's normal adjustment or coping. Of course, it's normal to be anxious when you get a new diagnosis, or sad, or mad. It's when it gets out of the ability for someone to cope that it's considered, and I don't really like the word disorder, but that's the technical medical term, right, is an adjustment disorder. So I'm having trouble coping the way I normally cope. The stress is getting to me. And then, of course, moving on towards what we would diagnose as a major depression, or an anxiety disorder like generalized anxiety, or a panic disorder, those kinds of things. So before I go on, is there any quick questions? Could take one or two. Okay, I'll move on. So the other thing that we have to think about, and it's often overlooked by medical providers and patients, is the medical causes of anxiety. So having neurological issues and syndromes can cause anxiety. Having hormonal imbalances, including the ones we impose on our patients with breast cancer or prostate cancer. Having electrolyte imbalances, having heart issues, having respiratory problems. I don't know what abnormalizes is. I just saw that on the slide. But having those problems, especially feeling shortness of breath, can cause a lot of anxiety. And so the point is, we have to approach what the cause is to address it. So if someone's anxious and it's because they're short of breath, it's not to give them a psychiatric medication or send them to therapy. It's to treat their shortness of breath, right? So drugs or medications as well. So caffeine, all the enes, cocaine, amphetamine, theophylline, corticosteroids, having too much thyroid hormone, which interestingly enough, this patient I saw yesterday also had. Her thyroid medication need had dropped, but they hadn't adjusted it. And so that was contributing to her anxiety as well. So when do we get concerned, or how does distress or anxiety impact us? Well, it's when it gets to the point where we're not able to do our daily function, our daily lives, or it's exceeding our ability to cope. So like I said, anxiety, distress is a normal part of life. It's when does it impair our ability to live life or to cope in life? If it's interfering with sleep, if it decreases our ability to focus, if we start isolating because of it or withdrawing from things because of it, if it's harder to be a caregiver or an employee, if it impacts your ability to make decisions, If it decreases people's ability to take their medications, because the medications are what's going to make them better. And the more cancer treatment somebody gets, the more likely it is to work. And so helping people get through the distress of that as best we can so they have the best chance of the medicine working. It lowers levels of exercise and healthy behaviors, which in turn are what are great for helping anxiety and coping. It can lead on to depression and anxiety disorders. And it also causes more missed appointments. And so people will have worsened symptom control and, as I just said, medical outcomes if they're not getting the treatment that they need. Also, just worsened immune system function, overall health, quality of life, and even mortality with out of control anxiety. So how do we approach distress, or what can we do? Well, one is education and self-management, learning how to cope, relaxation training, social support, exercise, and sleep, group and peer support, and that's what the cancer support community is all about, is group and peer support, as well as professional support, which also is the next bullet, individual or group counseling and talk therapy. There's also some existential therapies out there. There's relaxation techniques, which I mentioned with the training. And then when we need it, medications. When it gets to be really out of control, I like to use medications to extinguish those feelings of anxiety so that what's ever causing them is kind of like classical extinction. If you think about Pavlov's dogs and the bells and the salivating and how you get rid of that, if we can dissociate that feeling of anxiety from whatever's causing it, then it tends to get lower. And I like to do that quickly if we need it with medication. So what is self-management? It's active participation in problem solving, decision making, resource use, communicating with family, friends, support, and your healthcare professionals. I find a lot of do with my patients is empower them to ask the questions that they want answered and that are causing anxiety, and helping them to ask those questions of their oncologist, but also task planning and goal setting. When we have a sense of control over something that's not controllable, it helps with the distress and with the anxiety to some extent. So I saw one question, and that one I will save to the end about ADT effects on prostate cancer. Sorry, the comments are a little off to the side, so I have to look. Yeah, and we'll give people a chance to speak as well. We just don't want the background noise while we're talking, but you can certainly take yourself off mute to ask the question. So supportive counseling, improve people's understanding of the situation, what the potential outcomes are, the risks and benefits. What can you modify? Can you decrease your caffeine intake? Can you get more hours of sleep? Can you have a different perspective on what's actually happening and the amount of control that you have? Also, I find that I get reminding people of strengths and their coping strategies can help. I had a patient a long time ago. He was a senior executive responsible for half of the country for a company, and he couldn't tell his kids about his cancer. And I said, have you ever had to have a difficult conversation with an employee? He said, yes. I said, well, what do you do when you have that conversation? And he told me how he handles it. I'm like, you think that might work with your kids? And he said, I never thought of that. So just reminding him that he had the skills to have difficult conversations, emotional conversations in the workplace, that could translate over to his family, was helping. We often, sometimes when we're anxious or stressed, forget the tools that we've already built in life. And those are the ones that are going to serve us well. There's also psychotherapies, individual therapy, group therapies, and like I mentioned, existential group therapies that are focused on value and meaning. We offer a couple of those at Cedars. And of course, the cancer support communities around the LA Basin offer a mix of individual and group therapies. I'm sure you're well aware. So now I want to actually give you an example of a relaxation technique that you can all learn yourselves. You can teach people. I can teach people, in 3 minutes in my sessions with them. A lot of physicians get concerned that we don't have time to do this kind of work, especially like the oncologists or things. So what I want to invite you all to do is this is called guided imagery for those of you that might be familiar with it. I want you to all relax, get comfortable, take in this image. And typically I'll ask somebody to tell me their favorite place, their most calming place that I would know something about. I can't be their, house or their bedroom that I don't know. But for this, I choose the beach because it's fairly common and I have to know what we're doing. But so now I want you to close your eyes, relax into your chair, and I want you to imagine that you're at your favorite beach or this beach. And I want you to take a deep breath, let it out. And I want you to think about what you smell, the fresh ocean breeze, maybe some flowers nearby. Really take in the pleasant smells. And now I want you to think about what you're hearing. Try to actually experience the waves, the swells, the water coming up and receding from the beach. Maybe there's some birds, or you can hear the wind. Now I want you to think about touch sensations. Experience the breeze on your face, the feeling of sand between your toes or between your hands, your fingers. And now I want you to think about what you see. Maybe looking out at the sky, looking down towards the horizon where the ocean meets the sky, how the colors change and blend. And then now maybe the swells coming in from the ocean. You see the waves far out in the distance getting closer. You see the ripples in the water. You see the waves breaking on the sand. You see the transition between the wet sand and the dry sand. And now I want you to take a minute and experience all of those sensations together. Think about the sounds, the sights, the touch, the smells. Okay, now I want you to take a deep breath. Slowly open your eyes. And you can either type or take yourself off mute and tell me how you feel. Anybody? Very relaxed? Peaceful? Anybody almost fall asleep?
Yes, almost dozed off.
Almost dozed off? Yeah. Whenever I do this in big lecture halls, usually there's a couple people that fall asleep and there's also a couple people that don't relax at all. Anybody not relax? That happens too. That's why we have lots of techniques. Not everything's for everybody. But how long did that take? Anyone have a sense of how long we spent doing that?
3 minutes?
Or 3 minutes? Yeah, roughly about 3 minutes. Somebody said more in control, which is also helpful for anxiety. So yeah, so in 3 minutes, I've now taught you how to do this. You can do this yourself now. That's all it took. I have 3 minutes in my visits to teach patients this. But what I tell people with these techniques, whether it's this or progressive muscle relaxation or meditation, is you want to practice it when you're not in distress, because if you haven't learned how to do it sort of fluently and regularly when you're not distressed, it's not gonna come to you when you are distressed. So that for my patients, I tell them, do this 3 times a day, no matter what. But particularly initially when you're not distressed, so that when you are distressed, you have this tool in your pocket, because it's not the time to try something new or learn something new when you are distressed. Okay. So there's lots of complementary therapies. When I was at the hospice, we had over 100 different modalities of complementary therapies. These are just some of them. With the guided imagery that we just did, muscle relaxation. There's actually a lot of medical evidence for medical hypnosis, not show hypnosis, but medical hypnosis. Meditation, massage, aromatherapy, healing touch, pet therapy, energy therapy, biofeedback, always exercising if possible. And that can be as little as walking at a normal pace for 30 minutes or whatever you can do. Bright light exposure. So in Southern California, we're blessed with having a lot of sun. So getting out in the sun 30 minutes a day without sunglasses and without sunscreen, if you can tolerate it for 30 minutes, we don't want anyone burning. But getting that bright light exposure really helps. And of course, avoiding caffeine and alcohol and treating insomnia really go a long way for helping this. Then we get to our typical medication. So the antidepressants like the SSRIs, Prozac or Zoloft or Lexapro or Wellbutrin, which are good for long-term anxiety control. They can take 4 to 6 weeks to work, and on initial try, they only work about 30% of the time. If we try 2 or 3, you can get to 80%. So I like to use these if someone's really in distress or anxious when I meet them. Those are sort of my second line medications. The benzodiazepines are medications like Ativan or lorazepam, it's called, or Valium, which is diazepam, or Klonopin or clonazepam. And these are sedatives that can help immediately with anxiety and really dissociate that feeling, internal feeling with what's causing the anxiety. There's also medications you may have heard of called gabapentin, which is really good for neuropathic pain, but can also help with anxiety and insomnia. Or trazodone, which is an old antidepressant that doesn't work well as an antidepressant, but it works really well for sleep and in little doses during the day can also be helpful for anxiety. So with that, I've left plenty of time for questions, further discussion, and hopefully that this was a helpful high-level overview for you and gave you what you need. Please, for the future, let us know what else you would like to see that could be helpful. Like I said, happy to answer questions. I'm going to move this over. Let me unshare my slides. And I saw the one question already. There we go. Okay. So the name of the medication before trazodone was gabapentin, which is also known as Neurontin, and is often used for neuropathic pain. Can be used, it's actually originally an anti-seizure medication, but also works well for anxiety and sleep, and is a little bit more benign than the benzodiazepines, which have some other concerns. So all medications have risks and benefits, and We want to maximize the benefits while minimizing the risks. And if there are risks, then or you have side effects, adverse events, we want to find something else that's going to work for you. I really don't like it when I hear patients have been having side effects that are fairly intolerable for weeks and haven't had anybody address them. But I see that happen all the time with patients. So happy for you to take yourself off mute and speak up. Or I don't know if there's a raise hand thing in Zoom, because we usually use Teams, which has one of those, or continue to put questions in the chat or comments.
Dr. Irwin, we had that one question earlier. What is your recommendation for ADT effects in prostate cancer, exercise or other activities to help?
Right. So you're talking about the anti-testosterone or the anti-hormonal effects, I assume, of prostate cancer. So it depends on what the side effects are, right? So patients will feel like they can't think as well. Patients might feel depressed. There's obviously libido issues and other side effects. So it really depends on what's happening with them. Exercise and sleep are the two biggest things for anything you would ask me about. If people are depressed, then the antidepressants can help. I mean, the answer for both prostate cancer and breast cancer is to give them their hormones back. But we can't do that because the cancer is hormone responsive. So we have our other tools which can work to varying degrees. Also for the fatigue, sometimes stimulants can work. So the Ritalin, or Adderall, the ones we hear about for ADHD, also can be pretty good for depression and also sometimes for fatigue. Not often for cancer-related fatigue, but for hormone depletion fatigue, they can be helpful. So it's a little bit of trial and error, and it really depends on what you're trying to address. I always recommend any of the non-pharmacological things I mentioned today. Always. The medications should always be an add-on to those or done complementary to those.
Thank you.
Hopefully that answered the question.
Yes, it did.
Struggling with which friends to tell people. The reactions can be so hurtful. Yeah, that's a tough one about who to share with and who not to share with. And I find that patients are all over the map. Some patients really want to tell everybody and get support, and other patients really want to keep it to themselves and are afraid of being pitied or don't want to be defined by their cancer. And then we get all sorts of reactions from the people they tell, from a running towards the person in a good way to running towards the person to the point the person wants a break and doesn't know how to tell these people that they need a little less help and they need some time on their own, to friends disappearing or not interacting, or not knowing what to say or feeling uncomfortable. It really is all over the map. I would say be who you are. The comment on the side is looking for love and support. Hopefully, in your life who you can count on for that. The comment was the brothers are engineers. I used to work in San Diego, so I saw a lot of engineers from Qualcomm. And it was very interesting, their approach of wanting to know every number and every decimal on their labs and everything, being very, scientific, where some patients are, I don't want to know anything. And please don't tell me. I'm going to live my life the way I'm living it until I can't anymore. So it's really a judgment call. And if, I'd suggest if you need help sorting out for you who that is best for you, maybe a therapist could be helpful in that regard, because we're not going to have the answers. You're going to have the answers, but if you need help getting to those answers, a therapist can be really good. But I just find everybody is all over the map in both directions, who and how they share, and then how people react as well. The question about the fear of recurrence and that every twinge in the body is cancer returning. So I find that almost everybody has that, and we talked early on. I know you said that you came in a little late about fear of the other shoe dropping. That there's always this other shoe there, and so I don't see a difference for people in that. I see a difference in how they respond to it. In that some, it makes them incredibly anxious and impairs their ability to cope or to function. And others are like, yeah, this is just a part of my reality. And I know I can't predict the future. So it's really, for me, it's meeting people with how they cope, how they coped before they got cancer, how they're coping since they got cancer, and then helping them to cope best. Often with that fear of recurrence or that every twinge is something serious. Having a therapist to work on that with is really helpful, but also getting the oncologist involved and having a mechanism for the patient to have a sense of reassurance. Often more connection with a medical provider about those twinges can be really helpful in reassuring patients versus sitting there in fear or running to the emergency room or catastrophizing every little thing. Because we all have aches and pains and things, and as we get older, we get more of those. But sometimes those can turn out to be serious. And a lot of you that have been diagnosed or your loved ones, often it was something that, was little that led to the diagnosis. So, there's some healthy anxiety there that we don't want to ignore anything either, right? And so how do you balance that? How do you not let it overwhelm you? How do you cope with it? But also not blow it off. So chemo-induced neuropathy. So the medications that are quite often used are the one I mentioned, gabapentin, which is also known as Neurontin. It has a sister newer drug called Lyrica. Those are often in higher doses than what we use for anxiety or sleep. Cymbalta, one of the antidepressants, can help with neuropathy as well. I understand icing during the chemo or after the chemo to reduce blood flow could be helpful as well. So there are things I would definitely, if you're having those symptoms, talk to your oncologist, or if you have other specialists at your disposal. So we have a rehab, physical medicine rehab doctor that works a lot with neuropathy for our cancer patients as well. So typically I think of, and I will do this for the patients I see, by the time you're getting to me, you're at the second or third line of neuropathy treatment. But really, hopefully, you have access to either a pain specialist, a palliative care doctor, or a rehab doctor that can help with that if the oncologist is getting to the extent of their knowledge in managing it.
Dr. Irwin, I just have a general question. When you are navigating, or if a patient is navigating, feelings of anxiety, what questions would you recommend that they ask their providers? What I've gathered from a lot of our participants is when they're going through experiencing this, a lot of providers aren't very helpful in that sense, or maybe a little bit dismissive. What questions or what questions could they ask their healthcare team to really ensure that they're being listened to?
Right. So that's a great question, and it's going to vary by of course who you're seeing and where you are. Some oncologists are really attuned to this, others not so much. So one, I would let them know I am feeling anxious and it's in fact impacting my life. What resources or support do you have here at the cancer center, or that you know about in the community where I can get some extra help with my anxiety? Is there anything you can do to help me with my anxiety? And then I would remember that they're typically not the only person on your care team. Unfortunately, I see a lot of patients that their only care provider in their life is their oncologist. But many patients have primary care doctors, and they can certainly ask their primary care doctor, who treats a lot more anxiety and depression than their oncologist does. So also, utilize other people that's on your care team. Sometimes the nurses are more attuned to this than the oncologist, and so you might also mention it to the nurse. I'm feeling anxious. What supports do patients have here, or that you know about, that I can get help with my anxiety? The issue is, don't be afraid to ask. In all of healthcare, for all of us, including myself, even as a physician, having to advocate for ourselves. And then, of course, all of you are plugged into the cancer support community. And not only do they have resources to help you, but they also know about the other resources at your various places where you get your cancer treatment and around the LA basin. So they might be also a hub for information and guidance on how you can get help. My primary care won't prescribe any of the anxiety drugs that work. So then I would ask them to refer you to somebody that can. I don't know what that means, and all the drugs either work or don't work for an individual person. But if they're uncomfortable with some of the ones that I might be more comfortable with as a psychiatrist, and getting them to refer you to that resource is important. If you won't do it, who can assess me to, one, see if they're appropriate for me, and then two, prescribe them if they are. Referrals, more anxiety. I wish they had psychiatrists, oncology office. Yes. Well, some places do. So we do at Cedars, the bigger institutions, City of Hope. UCLA doesn't have it in the offices, but in a separate place. Of course, individual private offices, don't have that kind of access. And out here, in Conejo Valley, there's a shortage. Not many psychiatrists around, so that can be harder. But in this day and age with telepsychiatry and telehealth, hopefully you can get connected. That's been a big thing for us at Cedars. We have 7 cancer sites around the LA basin. It used to be that if you needed a psychiatrist, you had to come to the main campus. Now we can see patients all over the LA basin, whatever cancer site they're being seen at. And yeah, referrals can lead to anxiety because it's yet one more provider. You're getting a lot of providers through the cancer experience. And so it's nice when it's integrated into the program, so you're being handed off to a colleague than just somebody else and having to schedule something else. But on the other hand, if you're not getting the care you need, we want you to find the place. So somebody said they are getting care at Cedars. They have a social worker connected to counseling, Zoom visits, when could not get to Beverly Hills. So yeah, unfortunately, all of the cancer centers around the country vary in the amount of these kind of support. We're blessed at Cedars to have one of the more robust programs. City of Hope as well. UCLA is getting there. Other places, not as much. And again, out in the smaller and private, it can be a lot harder. So I'm in Ventucky. I'm going to guess, I've heard of Fontucky, so I'm going to guess that's Ventura. So the lack of resources out there. So I would try to take advantage of the telehealth that's available to you and telepsychiatry. And hopefully your providers can plug you in with that, or maybe somebody at the cancer support community or friends. But yeah, it's hard as we get out here. I feel, so I'm not quite as far as you. I'm just on the other side of the LA County line. And I think even out here, it's a challenge to get healthcare compared to being down, where the main campus of Cedars is. Cancer Center said there was a shortage. Okay, well, we need to ask other people then, because even if there's a shortage, there's still people to be able to help. So I'm not here to advocate to come to Cedars, and I think you can get great care at a lot of places around LA. But we do have patients that come from, Ventura, even Santa Barbara, the desert areas, and of course, some people, travel long distances, just like they do to the big cancer centers around the country, like MD Anderson or Memorial. Our closest site to Conejo Valley is Tarzana. There is a cancer site in Tarzana. That's a Cedars cancer site.
I have a comment.
Yeah.
I've received the most help from the nutritionist
Mhm.
with UCLA Health, and it's not so much. It's because she engages with me. She invests in the problems that I present, and that's what I've found frustrating is that most medical people don't seem to want to actually engage with me in order to solve a problem. It's hard to explain it, but I want someone to listen to me and hear what my problem is and commit to helping me find a solution. And um, my experience is you have to talk to a lot of people before you have to try a lot of people before you get to somebody who will engage with you in that way.
Yeah, I think that's a great point. And we have dietitians on our team too, and they're great, and actually also help with this it's a anxiety, especially around recurrence, because they're working on healthier eating and habits for reducing recurrence risk, and so that's a great point. And UCLA has a fantastic program. I'm really good friends and colleagues with the person that runs that program, and the way I sort of think about what you just said, from being both on the inside and also being a consumer of healthcare, is that for better or for worse, physicians have become very specialized. So before World War II, physicians had nothing but being able to talk to patients and morphine, and that was it. Now things have become complex. You just think about cancer care and how complex it is, and often a lot of those people are even specialized in what cancer they take care of, and I don't understand how they can spend 15 minutes with a patient and cover all of this stuff. And so I think about, what are people good at and what are they there to do and what do they think they're there to do? So in general, and these are blanket statements, this does not apply to everybody, and there's a whole spectrum. The oncologists are there to get rid of the tumor and make sure it doesn't come back. And in their 15 minutes, and for them to be good at and engage in the other things that are going on with their patients is challenging. And so that's why we take the team approach, where we have that group of people around you that, as a psychiatrist, I have more time to talk to you about those things and walk with you. Our dietitians do, our social workers do. The downside is that's more people to talk to, as you said, and some are going to be good and build rapport with you, some may not. But that's why really cancer care, and in fact, I think all medical care needs to be a team sport. The days of being able to rely on one person that can do it all is a challenge. And they don't have time. They also are getting pressure for how many patients they see, and how they get paid. And that's some of the pressure that we see, as well as how physicians get reimbursed and what they need to do to keep their offices open. Because I don't think a lot of them would choose to see patients for only 15 minutes, although some might. So it's a really good point, and I think it's a really good reminder to try to expand your team if you're not getting your needs met by the team that you currently have to the best of your ability. And now, so yes, COVID had many negative effects on our society and healthcare, but it also had the positive one of being able to do a lot of virtual care now and extend out to people that don't otherwise have resources in their communities. So I keep coming back to that as a way to take advantage of some of the things that are available to you now that may not have been available before. What should I ask for if Xanax barely works for anxiety and panic attacks going into chemo? So it's hard without, knowing you and all the other things around you to give you a specific example. But a lot of medicines in that same family as Xanax can work. The antidepressants can work. Xanax personally is not a favorite of mine. It doesn't last very long and it can cause withdrawal. And actually, a lot of people, once it wears off, get more anxiety. It has what's called rebound anxiety. So I never recommend Xanax to my patients, but I get a lot of patients that, like yourself, that have come to me on it. And so I work with it. The ones that last longer are ones I've mentioned. So lorazepam is on the, Ativan is on the shorter end, Valium or Klonopin are on the longer end. But again, really, you should get evaluated by somebody who can help you decide what's best for you and take it into context of all of your medical care, because some of these don't interact well with other things that might be going on. So I can't give her nothing that should be construed as medical advice, obviously, without myself knowing you and your history and exactly what's going on you. But yes, absolutely ask your doctor. So somebody asked if Cedars automatically arranges a team or if you have to arrange your own team. It's a little bit of both. So the oncologist is the hub of everything, and they have access to like our whole team. And so they can refer you easily to our whole team. And there's a team around that oncologist. So the social workers, dietitians are assigned to that oncologist. Our social workers, dietitians, spiritual care providers also try to be proactive and just meet patients and find out what their needs are as best that they can. But I'm amazed at the number of patients. In fact, I have a phone call with someone later today who didn't know how to connect their loved one with the services that we offer. But it's available to everyone getting cancer care at Cedars by a Cedars oncologist. And all of the oncologists know how to refer to us for these various services. We also have a team in the background where we screen patients for distress. We call it our well-being screen. And if patients have a high amount of distress but are falling through the cracks, they usually catch it and then connect people with the resources that they need. Are we doing on time?
We're doing
We'll have plenty of
good.
yeah.
I think we have time for maybe a few more questions if anybody has them.
Well, I certainly hope this was helpful. I purposely left a lot of time, one, to hear more about what would be helpful so I could also answer those questions and also just have plenty of time for questions and discussion. I know that's a little more challenging on the video than in person, but it's been a pleasure. I hope this was helpful. And I think we're doing depression again next week.
Yeah,
coming up soon.
Yeah, July. So the next session will be July 30th. We'll be touching up on depression there. It'll be the same format, Zoom, and then questions at the end. Yeah.
Great.
Oh, we did have one other question. Sorry.
Yep, I see it.
Okay.
So what would you tell a new patient on day of diagnosis to instill hope through this journey? It's a very complicated question. So number one, as soon as a patient hears diagnosis of cancer, they don't hear anything else that day. So that may or may not be the best day to talk to them. But quite often, what's the best thing to do for anybody in giving them news or instilling hope or whatever is asking them what they want to know or what might be most helpful to them. Because some patients will say, don't tell me anything. Some patients will say, I only want to hear positive things. Don't tell me any negative things, or tell me, tell my son, don't tell me. And then you have your engineers that we talked about earlier that want to know everything, and they want the most realistic, what is the data? What are my chances? What's the likelihood of this happening? So I don't have a one size fits all question or answer to that. But what I try to be careful of is not instilling false hope in people. And the reason for that is because sometimes things, and probably not at the day of diagnosis, there's a lot of unanswered questions at day of diagnosis. But as things progress and it's not clear how things are going to turn out, I would rather patients prepare for something bad happening and something bad not happening than the opposite way around, where patients would have prepared had they known and didn't, and then it's too late. So it's a fine line to walk, but I really don't want patients to have wanted to do something they didn't get to do because they had false hope or false expectations. But again, it's really guided by what the patient wants to know, wants to hear, how they accept information, who they want to hear that information from, because sometimes they want their cheerleaders to be their doctors, sometimes they want it to be their family, sometimes they don't want cheerleaders. So again, I feel like I don't have any specific answers for you, but very good, very complex questions and very individual. And maybe I'm highlighting for you how I approach patients, which is meeting them where they are as individuals. And I don't have sort of one size fits all answers. Right. So the specialists at Cedars are not automatic, but referrals. But if you can self-refer, you can ask your physicians, and hopefully you'll meet with the social worker or dietitian automatically when they can. So thank you all for the kind comments and thank yous on the side. Again, I'm here to be of service and help. So I'm glad that seemed to land for many of you.
Thank you so much, Dr. Irwin. It was a pleasure hearing from you, and we will see hopefully a lot of you back July 30th. Keep a lookout on your email. There will be a workshop survey being sent to your email just to get feedback on how today's presentation went. And we'll have the recording of this workshop up later on this week.
And please do fill out your evals, one, so I know how to do a better job, or they know whether to invite me back or not, but also Cedars asks to see those things for my faculty appointment too. So it's very helpful if you don't mind taking the time.
All right. Thank you so much.
Thank you, everybody.
Thank you.